welcome to our Facebook Live. Thanks for joining us. Today we're joined by Dr. Robert Sonnenburg of BayCare Clinic Ear, Nose, and Throat to discuss sleep disorders, and our health. Dr. Sonnenburg is double board certified by the American Board of Otolaryngology in Otolaryngology and Sleep Medicine. Thanks for talking with us today.
Thanks for having me.
Before we get started, as you can see, we're taking some extra precautions here just to make sure that we're all being safe and social distancing. If you do have questions about snoring, sleep apnea, or other sleep disorders, or treatment options, please feel free to ask them in the comments below. We'll do our best to answer your questions here in real time. If we don't get to them, however, don't worry. We'll answer online shortly after our live broadcast. So let's jump right into it. Let's talk about sleep in general. As a sleep medicine, ear, nose, and throat doctor, what are the most common complaints that you see people coming in for?
Sure. So there's a lot of possibilities for sleep complaints. People might complain of difficulty falling asleep, staying asleep, problems with movement during sleep, like sleepwalking, sleep talking, possibility of seizure disorders at nighttime. However, for most people that I see, they're coming in specifically about complaints of snoring or problems breathing at night.
Right, and you had talked about that there are specialists all over that deal with all those other things, but snoring is primarily the concern that most people bring to you.
Right, that's the most common complaint they'll see patients for.
So for people watching, how common is snoring and what are the types of issues that you see?
Sure, so snoring in and of itself is extremely common. Probably everybody snores occasionally. That might be from an occasional problem like you have a cold, so your nose is stuffy, or you go out for dinner, have a glass of wine, and you snore that night. Temporary condition, not something that's happening with regularity, and no serious consequences of that. Habitual snoring is also fairly common. If you look at individuals aged 30 to 60, just a little under half of men and a little more than a quarter of women snore regularly. In terms of the problems that causes, some of those problems are for the snore themselves. You can see problems with dry mouth, sore throat. Sometimes they'll wake up in the morning and their uvula, that little thing that hangs down in the back, will be swollen. Morning headaches, sometimes people complain of. Typically though, the bigger problem is we get from the bed partner. Because of their bed partner snoring, they're having a difficult time either falling asleep, staying asleep, sleepiness during the daytime as a result of that, and really a relationship problem. You know, when couples want to sleep together in the same room, however, one person snoring is disrupting the other person's sleep so much that they're just not able to do it anymore.
Absolutely, and I think a lot of people can probably relate to some of those things. If it is traditional snoring, what are some of the treatment options that you can recommend?
So lots of possibilities for that. Some of those things are just real practical, just sleep in another room. If you know your spouse snores once in a while, maybe either they or you go to the couch or to another room to sleep. When you have couples where one of the partners is snoring every night, a little tougher with that. I mean, some couples still choose to do that. But I've had patients do other practical things, earplugs or noise canceling earphones. Having the snoring partner sleep with their head elevated, that can help with snoring. Having them avoid sleeping on their back. So snoring typically is not as bad when people are sleeping on their side. Avoid things that contribute to the snoring. So if you go out to dinner and have a glass of wine and then you snore, just not having the glass of wine with dinner. If you take medications like pain medications or muscle relaxants, they can contribute to snoring. Talking with your family doctor about trying to be on the lowest dose as possible of those medicines, or if possible to not take those medicines anymore. There's also some medical options. So for people who have a stuffy nose, a neti pot that rinses out the nose and the sinuses, a decongestant like Sudafed sometimes can help. A nasal steroid is another prescription or also over-the-counter now medicine that people can try. There are some devices, something like a breathe right strip that helps open the nasal passages can be helpful. There's oral appliances or mouth guards that people can wear that are usually fabricated by a dentist or oral surgeon And then there are some surgical options. If people have an anatomic abnormality that's contributing to their snoring, like a deviated septum,
Right.
making their nose stuffy and plugged up, or enlarged tonsils, sometimes we talk about surgery for snoring.
Interesting. Well, if you're just joining us, we're here today with Dr. Robert Sonnenburg, an otolaryngologist with BayCare Clinic Ear, Nose, and Throat. We're discussing sleep apnea, snoring. If you do have questions about any of those things, please feel free to ask them in the comments. We'll do our best to answer those today in real time. We've just talked about snoring, and I know that snoring can sometimes be an indicator of something a little bit more serious. Can you talk about specific signs or things that people should be looking for just in case?
Sure, yeah, that's very common, and when patients come in and snoring is the main complaint, in my own mind I'm thinking, okay, does this sound like just regular snoring, kind of a nuisance, irritation, or is this a sign of something more serious, obstructive sleep apnea? And there's a couple of things that people can do that I use that are available on our website for people to look at, and that they could even do at home. And in particular, there's something called the Stop Bang Questionnaire. That was originally developed by an anesthesiologist to ask patients before surgery to see if they thought they would be at higher risk for having sleep apnea. Mm-hmm. And the Stop Bang stands for, the S stands for snoring, so do you snore, yes or no? The T stands for tired, are you tired during the day? I use something called the Epworth Sleepiness Scale to assess that, also available on our website if people wanted to look it up. Mm-hmm. It asks a series of questions about how likely you would be to fall asleep in certain situations. And generally, if a person scores 10 or higher, that would be considered to be abnormal. The O stands for observed apnea, so your bed partner sees you stop breathing. The P stands for pressure or blood pressure if you have or are being treated for high blood pressure. The B in BANG is body mass index, so an individual who has a body mass index of 35 or higher is at a higher risk. And that's something, there are body mass index calculators that you can find on the internet and put in your height and weight, and it'll tell you what's your body mass index. A is for age, 50 years old or older would be at higher risk. N is neck circumference, 17 inches for a man, 16 inches for a woman. And then G is gender, men get 1 and women get a 0 for that.
So that's a good place to start if they are maybe concerned that their snoring is something more than just typical snoring or occasional snoring, so to speak.
Yeah.
So I want to talk about obstructive sleep apnea specifically. What is it, and what symptoms would they be experiencing if they had something like some obstructive sleep apnea?
Sure. So obstructive sleep apnea is a syndrome where people have repetitive episodes through the course of the night where there's collapse of their upper airway. So their breathing passage closes and they're unable to ventilate. When that happens, the oxygen level in their blood decreases and their brain realizes something's not right here, and they have what's called an arousal, where they go from a deeper stage of sleep to a lighter stage of sleep. That allows those muscles to reopen and the airway to reopen and them to start breathing again until they drift back down into sleep. And when people have that, there's a couple of bad things about it. One is that it disrupts the normal cycle of sleep. So rather than having the normal cycle of sleep through the night where you're really getting good rest, it's disrupting that, and people's sleep quality is not as good. And then the other problem with it is that with those repetitive drops in the oxygen level and repetitive stimulations to you to arouse or have this awakening, it puts a stress on your heart and lungs. So when we look at the effects of obstructive sleep apnea, one is that with this disruption of the normal sleep cycle, people tend to feel tired. They tend to feel like their sleep isn't restful and restorative. Even if they increase the amount of time that they're sleeping or in bed, they just don't feel that rested. And that can result in problems with concentration, focus at work or school. People who have obstructive sleep apnea can be at higher risk of motor vehicle accident because they're not as attentive as they otherwise would be. The other side of it, the arousals, the low oxygen, obstructive sleep apnea has been linked to several serious medical conditions, including heart attack, stroke, high blood pressure, heart failure, and an irregular heart rhythm called atrial fibrillation. And it's actually is quite serious. When people have obstructive sleep apnea, they can die from it and from the complications that arise. Sometimes people will say, will ask me, in men versus women, do you tend to see the same symptoms or presentations? And unfortunately, there are some differences that are probably partly biologic and probably partly physicians' biases and not looking for it. I mean, the classic thing to think about is a wife who's unhappy that her husband is snoring. She's kind of a little bit worried and concerned that she sees these pauses, and a husband who really is asleep and not seeing the symptoms and not that worried about it. If you look at people, younger people, and women who are premenopausal, there's definitely a higher rate of obstructive sleep apnea in men than women, but in postmenopausal women, the rates are about the same. So in men, we tend to hear that they snore, they have witness pauses, they may feel tired, but often their bed partner is coming forward with the history. In women, we tend to get more complaints of feeling sleepy and like their sleep isn't restorative. And a lot of times I'll also hear women say they feel like their sleep is disruptive, so they're having awakenings at night. They can also snore, they can have the witness pauses, all of that, but I tend to get a little bit more from women. They just don't feel as rested and they feel like they're having more awakenings at night.
Interesting. What is the traditional treatment option for sleep apnea?
Yeah. So if a person, if there's clinical suspicion that they have obstructive sleep apnea, usually the next step would be for them to have a sleep study, either done in the sleep lab or as a home study to confirm that clinical diagnosis. And then if they have sleep apnea, it partly depends on the severity. So sometimes if sleep apnea is mild or positional, we might look at behavioral treatments like weight loss and or avoiding sleeping on the back if they're only having pauses when they're sleeping on their back. For most people, especially people with more moderate to severe obstructive sleep apnea, the traditional treatment is a CPAP machine. And that's a mask that you wear over your nose or nose and mouth that provides a positive pressure of air to the airway to prevent the airway from collapsing, to splint or stent the airway open. There are some really good things about CPAP. It's non-invasive, there's no surgery involved. It's a treatment that's been shown to be highly effective at helping people feel like their sleep is more restful and restorative, and also at lowering their cardiovascular risk. It's usually covered by insurance if people meet the right criteria. There are some downsides to CPAP too. Unfortunately, not everybody can get acclimated to it. Sleeping with a mask on your face, with the positive pressure of air in your upper airway, for some patients, they do it and it doesn't bother them at all. And some people, they really struggle with it and look for alternative treatments.
Right, and I think that's a great segue because I know that you're one of the only providers in this region who can offer sort of a new alternative treatment option for sleep apnea. Can you describe what that new treatment is?
Sure. So that new treatment is sometimes called an Inspire therapy or hypoglossal nerve stimulation. And that's something that patients, this is a model of the controller that patients use to activate their device. And I have a short video about it that shows how it works.
Sure, why don't we start there then?
Sure. Oh.
Apologies, we'll log back in here. Okay, there we go.
Okay, so this is an individual who's had a hypoglossal nerve stimulator placed, and here he is using his remote control to activate his device. And so when we look at this video, what we see here, this person, you're going to notice, they will be breathing in and out. And as they're breathing in and out, their airway, and this is supposed to represent their tongue right here, is going to be closing or collapsing. And that's what happens when people have obstructive sleep apnea. So there, the airway has fallen back right now. And this therapy is an implanted device, like a pacemaker. It gets implanted underneath the skin of the right upper chest, and it has 2 wires or leads. And this wire goes down and it goes in between the ribs. And what that does is it senses when the person takes a breath in. And when the person does take a breath in, it sends a message to the generator, which then sends a mild stimulation through this lead to the nerve that moves your tongue forward and stiffens the muscles of the upper airway. So rather than like CPAP pushes those soft tissues open, this actually stiffens the tissue and moves the tongue forward to open the airway up. And so this video is just something showing that, and then this is a cartoon showing the tongue actually physically moving with that stimulation to allow the airflow to flow in. Oops, sorry.
It's okay.
There you go.
Very interesting. Very interesting. So it works similarly to CPAP, but this is actually a surgery. Can you explain that process?
Sure, yep, that's right. So on CPAP, no surgery required. This does require surgery and the risks that go along with surgery, like a scar, bleeding, device malfunction, things like that. So, but for people who are the right candidate for this, who've tried CPAP, been unable to tolerate it, it's a surgery that's done under general anesthesia. They're out for it. I make 3 incisions, 1 underneath the jawline, 1 in the right upper chest, and 1 down by their ribs. I go to the nerve that stimulates the tongue and check the different branches. Some branches of that nerve move the tongue forward to open the airway. Some branches pull the tongue back. Some branches move the tongue to the side. We want to stimulate only the branches that move the tongue forward.
Mm-hmm.
And we're able to test that in the operating room. We put small electrodes in the tongue muscles, and I have a little stimulator that I can test those branches as we're dissecting them out. Then I put the lead between the ribs, between the muscles that sit between the ribs. When patients have had the implant done, there's about a week recovery period. It's done as an outpatient, so they come in that day, go home later that day. But we ask that they don't do any strenuous exercise or heavy lifting for about a week afterwards. We leave it inactivated for a month, as just to allow things to heal and for some scar tissue to form around the device. And then we activate it or turn it on in the office. And so patients come into the office, we give them their remote controller and show them how by pushing the green button and holding it over the device, it activates it. Initially, I set it on a low setting. Mm-hmm. And I do that just to let people get acclimated to what it feels like when their tongue moves. This is only activated at night when they turn it on, so it's turned off during the day. And we also set a range on it that allows them, if they're using it and it's not disturbing their sleep and they feel comfortable, to slowly increase the strength of the therapy. They come back to see me usually 1 to 2 months after doing that, and we have them have another sleep study in the sleep lab where we control the remote control, and we see what setting we need to set it on to help to keep the airway open.
Wow, but the remote actually gives them total control over the device.
It does. So they can not only in that early period where they're getting used to it, but also when we've picked the setting to have them use it at home, they can increase it or decrease it. So if they have a night where they feel like, oh, my tongue it's moving, I notice it, or it's sore, and they want to decrease their therapy, they can do that. If they have a night where they go out and, like we were saying, go to dinner, have a glass of wine, and they think, oh, usually I snore more when I have a glass of wine, and they want to increase it within a range, they're able to do that. If their spouse wants to do that, they also could do that. So if you have the implant and you're asleep, but you're snoring and he or she hears that, they would be able to increase the therapy until the snoring went away. And which is kind of a nice thing for couples when the person who has a sleep apnea is not aware of it and the other person is, and they can make some adjustments there.
Absolutely, very interesting. If you're just joining us, I want to give everyone a brief update. We're here today with Dr. Robert Sonnenburg, an otolaryngologist with BayCare Clinic Ear, Nose, and Throat. We're talking today about sleep, sleep apnea, snoring. If you have any questions about any of those, we are taking them live, so please feel free to ask those in the comments below. We've just finished up talking about this new innovative treatment known as Inspire therapy. There are some restrictions, or this may not be for everyone. Can you describe a little bit about that?
Sure. There are fairly strict inclusion criteria for who's a candidate for Inspire. It was FDA approved in 2014, so it's been around about 6 years that it's been FDA approved. And of those criteria, it's FDA approved for adults, age 22 or older. That they're actually working on lowering that to 18 now, but 22 or older is the original inclusion criteria. People who have moderate to severe sleep apnea, that is predominantly obstructive sleep apnea, so the upper airway is collapsing and closing. This helps to alleviate that. It does not help with central sleep apnea, where the brain isn't telling you to take a breath. We tend to see that in people with heart failure more, certain neurologic conditions, people who take chronic pain medications. And so there's an exclusion for that if it's mostly central sleep apnea. We like to see that people have tried CPAP and are unable to tolerate it. This is a therapy that has not been shown to be superior to CPAP. So CPAP is actually better at lowering your apnea-hypopnea index than Inspire is in general. And so if people can use CPAP, they should, because it's a very effective therapy. There is a restriction on people's body mass index, and that's a number that incorporates your height and your weight. That is less than 32 was the original inclusion criteria. We are seeing some flexibility with insurance carriers about that, allowing people up to a body mass index of 34. They've used a body mass index of 34 in Europe for several years, and it doesn't appear that people at 34 don't do as well as 32. And so I think we're seeing some loosening of that restriction, but 32 to 34 is kind of ballpark for body mass index for this. And then the final thing that we have to know is the pattern of collapse. And when I talk to patients about that, I simplify it in saying there's two general patterns of collapse. Your airway may collapse front to back. That's generally favorable for the Inspire. This moves the tongue forward and stiffens the tissue, so if your airway is falling back to collapse, this is moving in the right direction. There's another pattern that's sometimes called complete concentric collapse, or I say side-to-side collapse. If your airway is collapsing side to side, even if we stretch it more front to back, we're not opening the airway. So if you have that pattern of collapse, you're not as good a candidate for this. The way I know that, when I see patients who are considering this, we do a procedure in the operating room that's called a drug-induced sleep endoscopy. That's a brief outpatient procedure. People come in, we take them back to the operating room. The anesthesia doctor gives them some medicine to get them to drift off to sleep. And once they do, and we start hearing snoring and seeing some of these pauses, I look in with a small telescope to assess what's the pattern of collapse. And that's a step people would have to go through to really know if they're candidates for this.
Excellent, interesting. You had talked about CPAP intolerant. I want to talk about what that means from a general basis for somebody. Is it somebody who just doesn't like it, or is it somebody who literally can't sleep with the mask on? What is intolerant?
Pretty wide range. Okay. And generally for me, I really like to see people who just can't get used to it. And like when people come to me, they sometimes do, and they say, boy, I've been diagnosed with sleep apnea, tried CPAP 2 nights, I don't like it. Those people, I usually will say, have we really given this a good shot? Because there's lots of advantages of it. It's a very effective therapy. And sometimes there are things we can do to make it more comfortable for people. That may be adjusting the pressure, changing a mask, increasing the use of humidity, having a ramp up period where it starts low and then gets stronger as they fall asleep at night. And then there's other people who just absolutely positively cannot. It's very common for me to see patients in my office who've been diagnosed with sleep apnea 10 or 15 years ago, and they have 3, 4, 5 times been prescribed CPAP and never had in that 10 years a period of time where they've consistently used it. They might feel claustrophobic with the mask on their face. They might be a restless sleeper who tosses and turns a lot and the mask isn't sealing well on their face. I see veterans who have problems with PTSD who just absolutely cannot tolerate something being on their face at night. And it triggers nightmares and their PTSD symptoms. Those are people who would be the good candidates for this. You know, people have really given it their best effort and just not been able to consistently use it and get the benefit from it.
Right. Wow. So what if someone is currently using CPAP, has been diagnosed? What are their next steps as far as using Expire if they want to try it?
Yeah. So those people, I really ask them to take a long, hard consideration about why they want to change. You know, because if they're using it and they're using it effectively and regularly and they're getting the benefit of it and it's just kind of a hassle, usually then we're just talking and I'm saying, hey, so you know, this is more effective than doing the Inspire. It's a better treatment. And those people are usually just coming in to get information and say, okay, that's what I wanted to know. For the people who are using it ineffectively, they're using it less than half the nights. They're using it for a week and then they go 6 months and not using it. You know, those are the people who I think this really helps, that this really has the potential to benefit them.
Absolutely. And what are the next steps? Do they need a referral, or if they're already currently using CPAP, what do they do?
If they have a sleep doctor they're working with regularly, that's a great place to start. This is something most sleep doctors are familiar with and what the inclusion and exclusion criteria are, and they can give you good advice about that. They don't necessarily have to have a referral. They can come to me directly if they'd like to. I tend to see a lot of people who saw a sleep doctor in the past and aren't currently following up with one and who come to me directly. But I also see referrals from sleep doctors that are working with patients already, and then they get referred to me.
Interesting. And I know you talked about it a little, but as far as Inspire, is Inspire covered by insurance at this time too?
Yeah, so some insurance companies cover it, some have a written policy already, some do not. I tell patients in general, kind of assume it's going to be a case-by-case basis where I have to look over, see if you meet the right criteria, and submit it to your insurance. I will say that more and more insurance companies are writing policies about it now, and even in the last 2 years, we've seen the number of companies that are covering it has grown substantially. But it still is something, there are companies that don't cover it or require a peer-to-peer interview, an appeal, external review, and so it sometimes can be a process. But more and more we're seeing insurance positively cover it.
Excellent. I want to talk just about sleep apnea in general again. If someone's experiencing some of these symptoms that we talked about earlier, or if they do find that their bed partner is stopping breathing, that kind of thing, while they're sleeping, what do they do? What do you recommend?
Yeah, so that's something, I think there's a couple of things that are really helpful if people do on their own. One is to keep a sleep diary, maybe for 1 to 2 weeks, what time they're usually going to bed, how long it's taking them to fall asleep, how many awakenings they're having when they wake up, if they take any regular naps, if they use any medications to help them fall asleep, stay asleep, or if they use anything to help them stay awake. So doing that. On their own, they could look at the website, look at the Stop Pain questionnaire and Epworth Sleepiness Scale and see where do I rank when I take that questionnaire. Do I have a neck circumference of 17 inches? Is my body mass index greater than 35? And it'll give you a pretty good idea where you fall in terms of your risk with that. And then the next step would be either to talk to your family physician about it, who could refer you to a sleep doctor, or to make an appointment to see a sleep doctor. And then they could go through that information with you, do a physical exam to assess what those findings are and where they think that puts you with their risk, and then let you know, do they think you do need a sleep study, yes or no? And if you do need a sleep study, should that be an in-home sleep study or an in-lab sleep study?
Very interesting. Thank you so much for this information. We will post the links below the video for those 2 questionnaires that you mentioned, just so you can reference those as a first step potentially to helping you. And then we'll also continue to answer your questions online, so if you have them, please feel free to ask them below the video here. Again, Dr. Robert Sonnenburg is an otolaryngologist with BayCare Clinic Ear, Nose, and Throat. If you want to learn more about BayCare Clinic, Inspire Therapy, or request an appointment, you can go ahead and do that on baycare.net. Thanks so much for joining us today, and have a great day.